Hey friends, I thought it was time to get back to some note writing talks, and since 80% of my notes these days are on COVID, it's probably a good place to start. I think since many of you are students, this is also helpful because this is a brand new problem. It's probably not talked about much in the literature that you're looking at. It's probably not talked about much in your school. I know many of your schools are asking you not to go to places where you have to treat patients with COVID, which hopefully the tides on that are swinging because COVID's everywhere. So if you want to get your clinicals in, you got to take care of COVID. But in this video, we're going to go through the nitty gritty of how to write a note on COVID, in specific, the problem list under your note. So if that's what you're interested in, check out this video. If we haven't met yet, my name is Bree. I'm a nurse practitioner. I make content for nurses, NPs, and students. Welcome. COVID, schmovid. Aren't you all tired of hearing about this? Yeah, we all are, except you and I, because we work in healthcare, don't get the privilege of being able to stick our head in the sand and pretend like it doesn't exist. So we have to care for these people. Here's the caveat to this talk. This is going to vary a little bit, okay? I work at a couple different institutions. It's the practice and how it's treated is different at those two places. One place loves plasmapheresis and does it on a lot of their patients. The other place, we don't do it at all. It's also going to vary between your docs because, let's face it, there's not a lot of evidence to suggest that much of anything helps in COVID patients when they're ICU level. So there is, we'll go through each of the things and we'll talk about them. But because there's not a lot of strong evidence on anything that really works treatment-wise, you're going to get some provider eccentricities. Some physicians are really going to think, well, I like to try TOC, and some aren't going to want to try TOC. This carries over into all my note writing videos. Your note should be adaptable based on who you're rounding with, because ultimately you are the APP supporting the physician, and if the physician feels that this is our plan of care, that's what you're going to have to swing to. Obviously, I have my preferences, and one of the places I work, I practice very autonomously, so they kind of just let me do my thing. But I want to go through in specific what to include on this problem. And y'all, you're going to treat so much COVID that your note's going to be like boom, 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 just going to fly right through it. So this is the smart phrase I created. I'm going to show you a picture of in a minute. We're going to go through it. I highly suggest you get your own smart phrase because you can finish these notes in really, really quick, because ultimately these patients, they often don't have a lot wrong with them. I mean, sometimes they are going into some multi-system organ failure, but not most of the time. Most of the time, your problem list is going to include COVID and acute respiratory failure, and that might be it. So you can get through these notes really, really quickly, and that's good because you're going to have a lot of them to treat, and you've got problems at the bedside you got to take care of. Here's my soapbox that I say in all my videos. We have to focus on the big picture in these patients. The things that I communicate to my team when I'm signing off either in the morning or at night are the things I want you to include in your note, and those are the big picture items. And there are 5 of them in COVID patients. Your note should reflect all of these 5 things, okay? The first piece is timing and age. How long did they have symptoms before they came to the hospital? How long have they been in the hospital or/slash ICU? And how old are they? Because these things tell you volumes. I can communicate so much information by telling my night shift colleague who's taking sign out on 40 COVID patients, volumes about how sick they are when I say, this is an 84-year-old who's been here for 45 days on the vent. I mean, that's boom, mic drop. That's pretty much all you need to know with COVID. This isn't going to end well. That tells me a whole lot. Second thing, are they intubated? Self-explanatory as to why that's important, right? 3, how much FiO2 support are they requiring? Are they on APRV? Are they on 100% with a PEEP of 20? That's a little different than the patient who's on 40% with a PEEP of 5 and we're just keeping intubated because they have other issues. That tells me that their viral pneumonia is probably not their primary issue at that point. They've either gotten better or they had another problem that was the primary problem and not necessarily the virus that was creating their respiratory failure. That tells me so much. 4, are they proned? Currently, and how many times have they been proned? 5, do they have other organs that are failing? Because quite often these folks end up in renal failure and need CRRT or HD. Their shock doesn't tend to be a big problem with these people. So if they're in shock, they've got more going on than just the virus, and that's obviously worse. So those 5 things are the most important things to communicate verbally and in writing. This is the information I would include under the problem heading of COVID-19. What I want you to recognize is that quite often the assessment pieces that I'm going to include under this are very similar, if not the same, that I would include under acute respiratory failure. And in these patients, they should always have those 2 problems listed, always. Sometimes those are the only 2 problems that they have. But I want you to keep this problem concise and limited to just the COVID. Now, again, there are some pieces in here you're going to have to include about how bad the respiratory failure is, but it should be very broad, and that's what you're talking about under this heading, the virus and the main problems associated with the virus that you're assessing and treating. The first line is always going to say when you confirmed it via lab, because quite often they've been tested at some outlier facility before they come in. And then we retest them here. Sometimes we retest them multiple times, but all of this is pertinent. Everybody always wants to know this when they're looking at these folks. So include that as your first sentence. The second line is going to be how long were they sick before they came into the hospital. Timing is so crucial in these COVID patients because generally people are sick at home for 5 to 7 days before they come in the hospital. They're then in the hospital, like maybe on the floors for 4 or 5 days. They're then in the unit, and they could be in the unit for up to a month before they have to get intubated. But timing it tells me a lot about where they're at in their process. So I think it's very important to include this. I include a little snippet about their imaging. So I've got a chest x-ray with, generally you're going to have bilateral ground glass infiltrates. You may have a CT, which you can include the CT here as well. I think it can be relevant, especially a lot of ER providers are doing CTAs to rule out pulmonary emboli. So you can include that in here as well. Then you're going to include your ABG with your PF ratio, which tells you a whole lot about how profound their hypoxia is. You're going to follow that with the current state of things. So this patient has currently been on BiPAP for a few hours and is looking better. What I'm not going to include here is anything more than that. So I'm not going to go into the stuff that I would include in my respiratory failure tab, which is going to be like volume status, whether or not they have a bacterial pneumonia that I'm treating, all of the other things that could be contributing to the hypoxia. That goes under your respiratory failure tab, not under your COVID tab. Then on this one, I just put a general, COVID markers are elevated. What I think you should probably do, especially if it's the H&P that you're writing and not just a daily progress, is going to be to list out all of your markers, which is going to include your CRP, your SED rate, ferritin, fibrinogen, LDH, your lymphocyte to neutrophil ratio, your D-dimer. And D-dimer is super important, y'all. So and this example, I should have put for sure a D-dimer on there because your D-dimer is going to drive what level of anticoagulation you choose. Because as we all know, a major problem with this virus is not just the respiratory component, but the thrombotic component. In many circumstances, these folks die from PEs or thrombosis to other areas. So you need to really, if you do nothing else under this problem list, you need to include what your plan is for anticoagulation. Are you doing a drip? Are you doing BID dosing? What level of thrombotic risk are they at? And the thing about the COVID markers, the recommendation is every 48 hours to check these. At one place that I work, they do this by the book. Every 48 hours, they check markers. I would argue that it can be helpful because it gives you one piece of the puzzle to tell you the severity of this illness, which a large part of our plan, you're going to see in just a minute, is going to be assessing how bad it is, because that's what you're going to have to be reiterating to the families every single day. And if you have more data, you can give them better information. On the flip side of that argument, though, is really how does it change management? It doesn't. So do you need to keep checking these labs? I don't know. So I can see both sides of this argument. A lot of it's going to depend on where you work and the provider preferences and treatment options. So as you can tell, I created this template a long time ago when we were in our summer surge, and things have changed a little bit. These are some of the medications that we've been using. I'm just going to be frank, y'all. If it's my patient and I have full autonomy, I'm not giving remdesivir, I'm not giving tocilizumab or Actemra, I'm not giving convalescent plasma because honestly, none of them work, okay? There are no studies that show that these are providing clinical improvement. So I don't use them. Number one, I'm gonna go through why. Remdesivir, number one, It's expensive and it's limited in people who have an AKI, which many of these folks do. So why do it? Tocilizumab. I work with one provider who, if the markers are elevated beyond a certain point, he will use it. Personally, I don't see that it helps. What I see is that it suppresses the immune system and sets them up for other opportunistic infections. Now, his argument is that, well, I can treat an opportunistic infection, right? We have antibiotics. We have things that we can treat for that. I can't treat COVID. So he feels like Toci is having some benefit, but I don't see it at the bedside, and I haven't seen any evidence to support that it does. So again, provider preference. Convalescent plasma, I would prefer to not give it, frankly, because it doesn't help and it gives them more volume. And one of the few things I can do when I'm trying to oxygenate these folks is limit the volume overload in their lungs, and plasma is just going to contribute to that. So I would prefer to not use it. But often you get families or patients who request it. You get providers who still believe in it. So sometimes we give it. Steroids are the only thing that has shown a benefit. And it is small, but it's there. The debate is always been around what type and how much. I mean, there are some providers who will do Solumedrol round the clock. There's some that will do Solumedrol drip. There is a school of thought that Solumedrol penetrates the lungs better. The study that I've seen involved daily dosing of Decadron, so that's why it was included that way in this note. That's going to be your preference to make, but they should be on steroids. Side note about the steroids: put a stop date on them, or put something in your note that indicates to the person following you that they need to be assessed for when it needs to be stopped, because these folks are developing severe critical illness myopathy where they can't move anything except possibly wiggle their little finger. And that's going to lead to very long-term issues with morbidity, because they're going to have to all go to LTACs. And do you really need steroids? Steroids directly contribute to myopathy. So do we really need that? When they're improving from a lung standpoint, de-escalate the steroids. And the last piece is the anticoagulation, which we already talked about, so I won't go into that again. Now, if this is your initial note, each of these drugs might be included under the plan part of this note rather than the assessment piece. But for me, what I do is I put it above, because they're going to be on those for a little while. So I just put the dates in which they're on them and or the completed dates, because it's not something I'm changing from day to day. If you're changing it, if you're escalating the anticoagulation, that would go under your plan piece. The other medication that's not included on this list is ivermectin, because that retrospective study didn't come out until recently, but I have started using that. The two drugs I tend to use are steroids and ivermectin. Again, there's some argument about whether or not that is truly effective or not. That study was retrospective and there were a lot of confounders, but you know, to me, it's inexpensive. It has very few side effects. And what's the harm, right? It doesn't add any extra volume. It doesn't create too many other issues I got to deal with. And it has the possibility of some help. I mean, we need true randomized controlled trials, but that's down the road. What I can do now is just try this. You give a dose on day 1, you give a dose on day 3, and then you're done. I have seen some people get better that have been on it. I don't know if it was the ivermectin or other things. It's hard for me to say that, but because this is still early days of using it, but I do often include that. And plan. Well, this is the sad part of this note, because honestly, it's like, what can you do? I look at this, I do so good with the assessment piece of this note, and then I get to the plan and I go, well, I can pray. That doesn't look good on a medical note though. So, you know, there's not a lot you can say about this. You can write supportive care. You can write C, respiratory failure plan, because a lot of the stuff you're going to do is going to be to treat the hypoxia, which is going to be under your respiratory piece of this. So you can write prone, heavy sedation, treating the other causes of hypoxia. All of that can be under your respiratory failure note. So I wouldn't necessarily put it here, but you might put something like refer to problem number 1. But do the things to limit the hypoxia and help make them more comfortable, control their cough, help them to prone, get the volume off of them, treat bacterial pneumonia or anything else that's contributing to hypoxia. Speaking with the families every day, making sure they understand the full picture, making sure that's documented in your note, the overall prognosis. You know, this is an 80-year-old who's been here for 35 days on maximal support, poor prognosis, and ongoing discussions about goals of care. all the things you can do to support this patient and their family. Yeah, this plan piece, y'all, I wish I had more to tell you. I really do. But there's just not much to include here. The only thing you're going to include on this is any of those drugs listed above that you haven't started or that you're starting that day. You put down there, and supportive care. And that, y'all, that's really it. There needs to be something documented somewhere that gives the reader some indication of the overall prognosis. You know, this person is old, they've been here for a lot of days, they're on maximal support, and we're nearing futility. You can't say we're nearing futility, but you can allude to that based on what you're stating. So that should be somewhere in here too. I'm not saying it has to be under this part, but you might choose to put it there. And that, my friends, is all you can do for COVID. That's all. I should also add, you know, like I said, one place I work, they do plasmapheresis. So that's another treatment option you could put there. I'm not a fan of plasmapheresis. Honestly, I don't think it works. It's incredibly labor intensive. You got to put a big vast cath in. There are risk of complications with that. You know, it's all things you have to consider. Manpower is an issue right now with this huge shortage of bedside staff. I wish there was more that we could say that we can do to treat them. There's just not. Honestly, this virus is either going to take them or it's not, based on a higher plan than ours. And that's sadly about all you can do. But you can write a very well worded note. You know, take your kicks where you can get them, right, folks?